Okay, I'm gonna start with chapter 16 here. We'll see if we get through to get to another chapter on this one or not, but we'll figure it out. Okay, so these are the chapters from your MedSearch 2 book. So we're talking about the older adult in these. So some things we're gonna refresh on, and some things you'll be learning about. So make sure that you've read these chapters though. So vision, we know that vision impairment would have a great negative or would have a negative impact on the quality of somebody's life. And so there's different things that can cause these visual impairments for the older adults, and we're going to talk about each one of those, such as macular degeneration, cataracts, glaucoma, and diabetic neuropathy. There are different racial and cultural disparities in vision impairment that are significant that we'll learn about. So diseases of the eye, you have listed right there. So glaucoma. So there are different types of glaucoma. So there's congenital glaucoma, primary open angle glaucoma, low tension or normal tension glaucoma, secondary and acute angle closure glaucoma, which that last one is a medical emergency. Often the causes are unknown, and different things can be that can cause. Natural fluids of the eye are blocked by the ciliary muscle rigidity. Pressure builds and damage of the optic nerve occurs. So the eye has the damage back there behind it, and because of that pressure that builds up, it damages the optic nerve, which then would cause a decrease in vision. Bilateral glaucoma is typical, but it is more common in only one eye. So many times it'll only happen in one eye, but it can happen bilaterally. So for screening for glaucoma, adults that are 65 years of age and older need to have an annual eye examination. Those with medication controlled glaucoma should have those visions done every 6 months. So that's going to be part of our teaching that we're going to need to do with our families and patients about their getting their annual eye screenings. And if they have controlled glaucoma with medication, they need to be seen every 6 months. So those with family history, we're going to be teaching to be screened. And then so we use topical eye drops for management of the eye pressure. It can help to lower that. And then there's laser surgical treatments that can be done. So cataracts is our next one, is a condition that is caused by oxidation damage to the lens. By lens protein and fatty deposits occur in the ocular lens. So it is seen as a clouding of an ordinarily clear ocular lens. The red reflex may be absent or a pure black. Its most common causes are its familial or advancing age. So we want to teach our patients to increase yellow and dark leafy vegetables in their diet, and vitamin E from foods and supplements may lower the risk for women. And then if you see there, it occurs more frequently in those who are exposed to excessive sunlight, have poor dietary, have hypertension, have kidney disease, have eye trauma, but there's a lot of different things that can happen. So you have this fatty deposit of proteins and fatty deposits that happen in the lens itself, and then ends up causing this problem for the patient to be able to see. So a lot of times they have surgery. Many times that's like the actual not cure, I want to say, but the intervention for this. So it's recommended when the visual acuity decreases to 20/50. So 20/20 is your normal. So this would be 20/50, and it affects safety for the patient and quality of life. So we want to teach for the patient to avoid heavy lifting, straining, or bending at the waist because of the pressure that it would put on there. And we are also going to give eye drops for this, for the healing, and also to prevent infection after surgical intervention. So diabetic retinopathy, this is a complication of diabetes, and it is also the leading cause of blindness. Blood and lipid leakage leads to macular edema and hard exudates, and no symptoms occur in the early stages. So if you remember, we were just talking about diabetes before in the last couple weeks, that this is one of those complications from, remember, there's too much sugar in the microvascular system, and so I'm causing damage to the vessels and then damage to the vessels around the eye, and so that makes them leak, or they make them weak, and then they leak and they cause this edema. And so what ends up happening is that because of the pressure and because of the damage and because of everything else, we end up getting this decrease in vision and eventually blindness. And all of this is uncontrolled sugars that starts all of that. So screening. So obviously our early screening is going to be with teaching our diabetic patients and keeping control of their glucose, and then you'll see in there too cholesterol levels, blood pressure, and again, all those things go together. So understanding the whole pathophys around diabetes itself, and knowing what's happening in those vessels can help us with that. But under here, and I see that this is kind of messed up. Early signs observed, something, examination, and some type of examination that I can't read, are microaneurysms, so little tiny bursts of blood vessels, flame-shaped hemorrhages, cotton wool spots, hard exudates, and dilated capillaries. So, the vessels are trying to compensate for all this stuff that's going on. And so this can be seen in vision screening. So again, this is another population that, remember, with our diabetic patients, we're telling them that they need to have annual eye screenings. And this is the reason why right here. And then macular degeneration is the leading cause of vision loss in Americans who are 60 years of age and older. Its prevalence increases with age, causes progressive loss of central vision, leaving only peripheral vision intact. So imagine that sight in front of you is progressively going away and you can only see on the outsides. That would be super difficult. Early signs are blurred vision, difficulty reading and writing. You can read the rest of that stuff. So this is another thing that we're going to be dealing with our older population. It's important for us to understand and know, and if our patient's alerting us to stuff like this, that we're getting the doctor to see them. So age is your greatest risk for that. And then you have other risk factors listed here for you. There's 2 forms. And then the Amsler grid is used to determine the clarity of vision. So you can look up Amsler grids so you're aware of what that is, but it's good for you to do some research on that as well. And then detached retinas, these can occur spontaneously or after a cataract surgery or some kind of eye trauma. So it exhibits a curtain coming down over the line of vision, and this is definitely a medical emergency. Because the retina is coming apart from the rest of the eye. So that whole curtain coming down. So imagine like your vision is just slowly going away, like a curtain is coming down from there. And then dry eye is a huge thing that we're going to have with our older patients. Much of it is side effects, because we have all those medications we use that are going to do the drying of things. So much like we talk about dry mouth, dry eye is another one. So we have things like artificial tears. We can teach to use a humidifier, avoid wind and hair dryers. Interventions to enhance vision. So you can read through these right here about the lighting and controlling glare, avoid contrast colors, and then recommending reading materials in large dark print. And we have a lot of that now, more so than we ever have, where there's a lot of the bigger print and, better contrast on the pages. Low vision assistive devices, so you can read through this too. If all of the pharmacies now have the glasses that are basically magnifying glasses. And then, the different like big face watches, but there's talking clocks and watches. So things that we can help them if they can't see well. These are the different assistive devices for our older population. So implications for the geriatric nurse. Again, I've got that kind of mixed there a little bit. So vision impairment is something we're going to deal with the older adults. And so our concerns, making sure we're doing that appropriate assessment, like the things what we were just talking about with macular degeneration or diabetic neuropathy, cataracts and glaucoma, that we're screening for and doing the right assessments for these things. We're getting the information from them that we need. We're teaching them appropriately and giving them the resources to things like assistive devices, and then giving it referrals, and again, the teaching. So then our hearing impairments. This is the third most chronic condition in the American adult older population. So of those who are 80 years of age and older, 90% of those people have some sort of hearing loss. So imagine putting something in your ears and you can't hear anymore. So it's going to be difficult. It's underdiagnosed and undertreated for the older adult population, and the reason for that being is that our patients don't want to report this to us, right? Because people don't want to be faced with the fact that they're losing their hearing. That's a big thing of life, being able to hear. So knowing that we need to make sure we're doing the right kind of assessments for that. So types of hearing loss, there's conductive loss. Involves abnormalities of the external and middle ear, which reduces the ability of sound to be transmitted to the middle ear. Is caused by otosclerosis, infection, perforated eardrum, fluid in the middle ear, or wax accumulation. And then there's sensory neural loss is the result of damage to any part of the inner ear or by the neural pathways of the brain. So you just want to know that though there's the hearing loss, we got to get down to the bottom of what is it exactly that's going on that's causing the hearing loss itself, but that there's more than one type of hearing loss. Tinnitus is the ringing in the ears. So we actually see that throughout much of our population. So also it is the perception of sound in one or both ears, or in the head when there's no external sound present. So you'll find many people have to use, or like have white noise or sleep with a fan, in order to kind of drown that out. So exposure to loud noises is the leading cause. So especially in our area, different men and women who have worked in the shops, concert goers, are all at an increased risk of having tinnitus. So with our patients, on our assessment, we may not know the cause. It might be pulsating or non-pulsating. We can have them keep like a diary of when they're hearing it and when it's coming on. And then so actually evidence indicates caffeine, alcohol, cigarettes, stress, fatigue can exacerbate the problem. So we want to teach about control it, trying to decrease stress, not drinking, not smoking, not drinking a ton of caffeinated beverages, and getting good rest. And then medication as well, because some medications can cause tinnitus. So interventions to enhance hearing. So hearing aids, we're definitely going to work with patients that are going to have hearing aids. And then, again, we're going to have to assess financial resources because those are not cheap. And then you'll also be able to learn about cochlear implants. Those are also used. You can read about those in your book. And then other assisted listening devices. Some more implications for the geriatric nurse. Again, hearing impairment is going to be a common complaint of the older adult, but we need to ask the right assessment questions to determine if that's going on. Inadequate communication with the older adult who has a decrease in hearing can lead to a misdiagnosis or affect his or her medical regimen. So it's so important that we make sure that they understand and can hear us. Maslow's, I've always got Maslow's stuff popping in and out, so you can read through that. And then I'm not going to be able to move on with the next chapter on this one, but I will go ahead and record that next.